Evening, everyone. Today we are starting cardiology. First topic is going to be a chest pain or approach to chest pain. Chest pain is one of the common symptoms that patients present with to the emergency department or clinics, and it can be cardiac or non-cardiac. Cardiac, such as coronary syndrome, dissection of aorta, um, myocarditis, pericarditis, non-cardiac, such as pulmonary embolism, pneumothorax, etc. It can also come from muscles or joints. Costochondritis is one example of musculoskeletal chest pain. GERD can sometimes present with chest pain. We will learn in this lecture how to approach a patient who is presenting with chest pain, or how to go stepwise to diagnose and appropriately treat patients who are presenting with acute chest pains. First thing first, patients with chest pain, they are high priority in triage. So whenever nurses hear someone say they have chest pain, specifically if they say their chest pain is also going to the arm or jaw, they triage them with high priority and send them in to be seen quicker by a physician. Goal in chest pains is going to be ruling out life-threatening conditions such as acute coronary syndrome, acute aortic dissection, pulmonary embolism. Our focus is on cardiac assessment first, and we are not allowed, or we should not assume benign etiology based on patient presentation. Up to 40% of chest pains are not typical, or up to 40% cases of coronary syndrome are not typical chest pains radiating to the arm. They can be silent, may present with shortness of breath, or they may have a localized pain versus pain radiating to the left arm or jaw. We will use clinical decision pathways for stratifying the risk and then going ahead with either following up the patient in community, admitting them to the general medicine ward, or sending them directly to cardiology ward or cardiac lab, catheterization lab. Now, when patient comes in with pain, we can use this PQRST structure to help us determine what our next step would be. P, what provoked the pain? Was it exertion? For example, it's winter now, most people are shoveling snow. Was the patient shoveling snow when he started feeling the chest pain? Was it emotional stress or emotions or stress or a big meal, or did it start at rest? Usually IST or ischemic pains, they start at exertion or in status of high emotions. Pains that start at rest, they can be either unstable angina or other causes, but cases of stable angina or ischemic heart disease or ischemic pains, they usually get worse or start on exertion. Quality, what does the pain feel like? Does it feel like pressure, or like something is heavy sitting on the chest, or does it feel like someone is squeezing you from the inside? It's very specific for cardiac if they say they have squeezing type or pressure like chest on the heart. Or is it sharp? Is the pain sharp or pleuritic? Sharp pain is usually from non-cardiac causes. Pleuritic pain is obviously from the pleura or from pulmonary causes, but sharp pain can be from pericarditis or another reason. Now, R stands for radiation. Is it going to the arms, either arms or both arms, the neck or jaw or the back, or is it just localized chest pain? In acute coronary syndrome, we usually see radiation to the neck, to the jaw, neck, and arms. Chest pain that's tearing in nature and going to the back or to the posterior side of chest, it's usually a sign of or representative of aortic dissection. We would ask them about severity of the pain. How severe is the pain from 0 to 10? Ischemic pains, we all know they are extremely severe. Sometimes they can be 10 out of 10 pains. Non-ischemic pains will be 6 or 7, but we cannot say it's non-ischemic pain if patient rates is as 6 or 7. Every patient's perception of the scale is different, 0 to 10. Some patients would call anything 10 out of 10 pain. Others would be like, oh, it's a 5, but in reality, they will be 10 out of 10 10. Again, with S, we would also check for symptoms. When there is acute ischemia ongoing, sometimes acute MI or STEMI or NSTEMI patient may feel diaphoresis, sweating, nausea, dyspnea. T, we come to time. How long is it going to take us from door or emergency room door to balloon or to the area where we do PCI? This will help us in deciding whether we are going to go with primary PCI or fibrinolysis. Now, here are some descriptors for cardiac or possibly cardiac pain versus non-cardiac pain. Cardiac pain feels like pressure, squeezing, heaviness, tightness, burning. Burning is also more specific for GERD or reflux, but it can also feel like burning, but usually it would be very non-specific area. It is usually exertional. It feels like it's behind the chest wall. So patient would say it's like on the inside, and usually it's radiating. Non-cardiac pain, it is sharp. It may be sharp, it may be pleuritic. It could change with position. For example, in pericarditis, if patient leans forward, their pain gets slightly better. If they get upright or lie flat, their pain may get worse. Or it could be reproducible on palpation, such as costochondritis pain. If you palpate the costochondral joint, they would have worsening of the pain that they were experiencing, or in other words, tenderness at the costochondral joint. Now, physical exam findings. These are some critical exam findings. Look at heart rate. Are they tachycardic? Look at blood pressure on both arms. In aortic dissection, sometimes blood pressure can have discrepancy in both arms. One arm would show 160 over 100, the other would show 100 over 60. So if there is discrepancy of more than 15 or more than 20 millimeter ATO, a millimeter of mercury, think of aortic dissection. Look at their saturation, oxygen saturation. If O2 sat is low, even if it's STEMI, we would consider giving them oxygen. Look at the respiratory rate. Are they tachypneic? Tachypneic could indicate a pulmonary embolism. Look at the temperature. Do they have a fever with it? If it is a fever, it could be endocarditis or pericarditis or pneumonia. Anything that would be infectious in origin, it may have fever or temperature, high temperature with it. Look at the general appearance of the patient. Patients with cardiac chest pains, they're usually in distress. You can look at their face and you can see that they look pale, they're sweaty, and they look in acute distress. Look at or palpate the chest wall. See if they have any muscle spasms or tension, or if they have any points where pain is reproducible on palpating. For aortic dissection, remember BP in both arms may be or is most of cases, it's different. If it is different, we are going to be thinking of aortic dissection versus other causes of chest pain. Now, what are some diagnostic tests that we have to do? First, patient with chest pain. Every patient with chest pain who comes to the emergency department, they need an EKG. This will almost always be done for all patients. The goal is to get it done within the first 10 minutes. This will be ideal, but we would still want it to be done within the first half hour, if not in the 10 minutes. In cases, sometimes they do not appear to be cardiac or any other reason, they may get delayed, but within half an hour should be the latest goal to get the EKG done. 10 minutes, this is the ideal goal for us to do the EKG at least. Now, how do we interpret EKG? Look at the ST segment. Is it elevated? Is it depressed? Is there any T wave changes? Is there any new bundle branch block? Do they have any arrhythmia on the EKG? If EKG or ECG is normal during pain, up to 6% of patients still have risk of ischemia. Repeat ECG if there is high suspicion. Now, Consider posterior leads V7 to V9 for patients with chest pains who may have some changes in leads, in inferior leads, or if there is non-specific T-wave, S-T-wave changes in the inferior wall leads 2-3 AVF, we can check that with posterior wall EKG or posterior EKG, V7 to 9 or V4R, V5R, V6R. Three leads are used to assess for the posterior circulation. Now, second test that we would do for someone with chest pain in case of EKG being negative or EKG showing non-specific changes is to do high sensitivity troponin IRT. We do it in serial or series. We don't just do one and then send them home. High sensitivity, this is the gold standard nowadays. Previously, we used troponin IRT, which were not as sensitive for cardiac muscle necrosis. Nowadays, these high sensitivity are more specific and more sensitive, and they have a high negative predictive value. So if they are negative on multiple checks, it usually means the patient doesn't have any cardiac pathology. First sample to be done at arrival, then 3 hours, and then 6, and then 12 hours. We can repeat it. Usually, this high sensitivity troponin, they can give us a result in 2 to 3 hours after chest pain starts. So we can do 2 of them to make sure that the patient's chest pain is not cardiac in origin. Now, what they do is they detect necrosis or damage to myocardial cells. They do not care about the mechanism by which the coronary syndrome is occurring. So if it is a plaque rupture, as in acute STEMI, or if it is a partial occlusion, it just shows necrosis. We do not really determine if it is from an acute plaque rupture and causing full occlusion or partial occlusion, STEMI or non-STEMI, we don't care. It will just give us an idea of necrosis. We do a third sample or a repeat at 24 hours if the previous 2 are negative, but still we have a high suspicion of an MI. The only caveat with this is that we get false positives if patient is in sepsis, if they have renal failure, or if they are in heart failure. In those cases, it may not be as accurate, but in other than that, usually they give us a pretty good idea of whether a patient's pain is cardiac in origin or non-cardiac. Okay, now how we decide what to do for what patient. We use a score that we call HEART. We will discuss what HEART stands for. Low risk, intermediate risk, high risk. Low risk, we don't do more testing. We can discharge them safely and then follow them up in community and consider stress testing if we think they may have stable angina or their pain may have been angina or in origin. Intermediate risk, we can then do coronary CT angiography, as it is preferred over stress testing. Since they have intermediate risk, we do not want to cause an acute MI or an acute ischemia. High risk patients, we can consider invasive coronary angiography. We either use PCI or CABG. We decide once we determine that they're high risk, then we decide on based on how long it has been going on, how many vessels involved. We will discuss those algorithms for when to do PCI or when to do CABG later on. Yes, Dr. Shri, you have a question?
Yeah, I was hoping if you could explain why there'll be false positive with sepsis. Is it like in the case of like pericarditis or something? I don't know. I just wanted to get how the result would be false positive.
Okay. So sepsis, kidney failure, in those cases, the result will come false positive. It means that the body may produce the troponins. It's not that there is any inflammation going on in the heart, but the body may produce it. That's why it's false positive. All right. Okay.
Okay.
Yes. So now if we come to cardiac chest pain or chest pain due to cardiac reason, um, some of them are life-threatening if left alone. Some of them may not be acutely life-threatening, but are still dangerous. Now, first or most dangerous or most worrisome is STEMI. If patient has typical chest pain and you see ST elevation on EKG, 2 mm or more on chest lead, 1 mm or more on limb lead, and we have less than 90 minutes ideally for from door when they arrive at the emergency room to balloon or cardiac catheter lab. In that case, we will consider them a good candidate for primary PCI or PCI directly without waiting for thrombolysis or other reperfusion strategies. In STEMI, it's also life-threatening. Unstable angina, it can be life-threatening in case there is ongoing uh, issues with the circulation or ongoing exertion or ongoing emotional changes. In those cases, you will see ST depression, specifically for NSTEMI, T-wave changes in NSTEMI, and elevated troponin in NSTEMI. Unstable angina usually have negative EKG and negative troponins. Difference between unstable and stable angina comes back to when the pain occurs. In stable angina, usually occurs on exertion, gets better with rest or nitroglycerin. Unstable angina, it may start with or without exertion and does not improve with rest. Pericarditis is another condition that can be life-threatening, especially if there is a large effusion. In this case, they will feel pleuritic chest pain, which is sharp in nature usually, and it gets better by bending forward or leaning forward, gets worse if they get straight up. EKG usually shows diffuse or global ST elevation. You may also see PR interval depression. Myocarditis usually is post-viral. You would see it in patients or usually in patients who have a viral URI symptoms like a sore throat or runny nose, something like that. And then after a few days, they develop signs, chest pain and symptoms of heart failure. Think of myocarditis. In myocarditis, you will see that troponin are elevated and they may have arrhythmias. Other non-cardiac causes, other acutely life-threatening diagnoses for chest pain, aortic dissection. If it is Stanford type A, it can be acutely life-threatening. Type B can also be life-threatening if not quickly managed. Pulmonary embolisms can be life-threatening. Tension pneumothorax, which is life-threatening within a few minutes if not corrected quickly. Now, in aortic dissection, usually the pain is described as tearing and it's going to the back. And you may see that their pulse or blood pressure is different on one arm from the other. Pulmonary embolism, it usually has this deep, sharp pain. They feel dyspnea, they have tachycardia. And then when you check their Wells score, it's above the threshold and diagnosed by CT angiography. Tension pneumothorax usually occurs in trauma cases. It presents with acute dyspnea or really bad shortness of breath, hypotension, and absent breath sounds on the side that's affected. When you do percussion, you will see that it's hyperresonant. You will see that their trachea is deviated. If you see this presentation, the side that doesn't have breath sounds, you quickly do a tap or a needle, insert a needle into the chest wall to release the air, make it open pneumothorax, and then do a chest tube. We do the needle first to buy us time. You can do chest tube if you have like a really good system and you think you can get it done quickly. Now, non-cardiac causes, they're very common to cause chest pain. Musculoskeletal or costochondritis, it's reproducible on palpation, chest pain that's reproducible on palpation. GERD is also a very common cause of chest pain. Usually it's described as burning right here in this center of the chest. With GERD, they may say it gets worse after food or it gets worse 2 hours after eating. and usually gets better with taking over-the-counter antacids like Tums or PPIs. Anxiety and panic attack, they can be hard to differentiate from acute coronary syndrome because the symptoms match so well, other than the fact that the patients are usually hyperventilating and they feel uh, like everything is closing on them, or they have like this sense of impending doom, which can also be seen in MI. But in panic attacks, usually patient gets a panic attack because he's thinking of getting a panic attack. So, and they usually have a history. This may be a point that differentiates it. But in all cases, even if we are suspecting a panic attack, we have to first rule out cardiac causes before we say a patient has a panic attack, because panic attack, especially if it's the first episode, we cannot say without ruling cardiac causes out. Now, pleuritis or inflammation of pleura, it can also cause pleuritic chest pain. It's usually positional, same as pericarditis, and usually can happen after a viral illness or a viral URI. Now, diagnostic imaging, usually they're preserved for specific cases. If someone has acute chest pain and we determine that they have intermediate risk, but they do not qualify the criteria for undergoing catheterization or in angiogram or another invasive procedure. So we can do coronary CT guided angiography for them. It's faster and usually does not make things worse. In intermediate risk, we are obviously worried about them getting an ischemic attack. That's why we would avoid stressing the heart. If there is a blockage, we can cause a acute ischemia, and we don't want that to happen. Echocardiogram, bedside echo, you can do it if you're suspecting aortic dissection, or if you are suspecting myocarditis or pericarditis, you may see a pericardial effusion. In tamponade, you may see fluids around the heart that's making it hard for the heart to beat. Still, CT guided angiography is the gold standard for diagnosing aortic dissection and pulmonary embolisms. Chest X-ray is not routine. We consider it if we are suspecting pneumonia, pneumothorax, heart failure, or if patient had trauma that caused the chest pain. Now we are worried about uh, aortic dissection, so we can do a quick portable chest X-ray before going to the other test to see if the mediastinum is widened. If it's widened, it's very telling of aortic dissection. We then follow it up with a CT angiography. If patient is stable, if not, then we can do a bedside echocardiograph. Now, some patients may come with chest pain that's chronic or that happens when they're doing something strenuous like shoveling snow, or when they're in emotional state. And it's predictable. Patient knows it happens with exercise or stress, and then gets better if I sit down or take this sublingual nitroglycerin. CAD or coronary artery disease risk calculator, you will use this in hospitals. It will help in guiding the need for testing. If patient is low risk, you don't need testing no testing needed. You can still do it, but it's not needed. If it is intermediate to high risk, then consider either stress testing, angiography, or CCTA or coronary CT angiography. Now, some patients may present with atypical chest pain. Women, the elderly, diabetics, they may not have chest pain. They may come with shortness of breath. They may come with another symptom. They may come with a localized chest pain, not the specific squeezing chest pain going to the arm. Women, they present most commonly present with dyspnea, nausea, and neck or back pain, not chest pain, jaw, neck, or back pain. Patients who are elderly, especially if they're above 75, they may present with the feeling of syncope, or actually getting like collapsing or having a syncope episode. They may come with changes to their mental status, or they may come and say, it's hard for me to breathe all of a sudden. Now, diabetes, these patients usually have no chest pain. They have very minimal symptoms because of neuropathies and autonomic dysregulation, etc. They may not feel the chest pain. Sometimes they also present with shortness of breath. It's acute in origin and cannot be explained by anything less. Remember, for these three groups, your threshold for doing acute coronary syndrome workup should be low compared to someone who doesn't belong to these three. Now, once we determine what is going on, so what do we do? Do we send the patient to CCU or coronary care unit or cardiac care unit? Yes, if they have STEMI, if they are high risk in STEMI, if they're unstable, they have unstable vitals, or if their ischemia is refractory to anticoagulation, etc. Chest pain unit or medicine unit, low to intermediate risk patients who need observation, those will go to medical unit. Discharge patient who are low risk with negative workup, you just need to you can discharge them home and then ask them to follow up with family doctor to be referred for chest test, stress testing or other tests if the family doctor thinks they need it. Now, we determined patient has acute coronary syndrome. What do? We start with these medications. Aspirin, 160 to 325 milligram. 160 is usually for patients who are thin. 325 you can give to patients who are slightly, whose body mass is higher. If there is no contraindication, you can add a PGY12 inhibitor, ticagrelor 125 milligram or clopidogrel 300 or to 600 milligrams. Oxygen only if their saturation is less than 90%. Nitrates or sublingual nitroglycerin, you can give it to patients with chest pain, but you have to monitor their blood pressure because right-sided MI can usually present with hypotension, and if you give them nitroglycerin, you will make it worse. They can go into shock. Analgesia, morphine is given to patients whose pain is extremely severe and refractory and not getting better with the nitroglycerin, anticoagulant, etc. Anticoagulation, regardless of whether it's a STEMI or NSTEMI, you do a loading dose of heparin, 4,000 to 5,000 units, bolus, and then you follow it with IV infusion. The good thing about heparin is that it can be quickly reversed with protamine if we need to consider surgery or surgical treatment for the patient. So we can just give it to the patient, give the bolus, and then start IV infusion, and then wait for cardiology to determine if they want to do quick cabbage or if they want to do PCI. But again, we have to give it to patients if they are presenting with acute coronary syndrome. In STEMI, our goal is to do immediate revascularization. From the door of the ED to balloon or where we are doing the PCI, ideally within the first 90 minutes, but we can extend that period to 120 if we are transferring patient to another hospital or to another facility. In most cases, we want to do it within the first 90 minutes. It has the best outcomes. Now, some clinical pearls or clinical high yield points. If patient has normal ECG and they have chest pain, it does not exclude ischemia. Response to nitroglycerin, it's not a diagnostic test. It does not mean they have ischemia. Troponin elevation occurs 2 to 3 to 6 hours after symptoms start. Repeat at 3 hours if initial troponin level is normal. Now here's how to approach a patient with chest pain. Take a history, do a physical exam, go to EKG, do an EKG, then biomarkers, and then stratify their risk. Go to imaging or intervention based on what their risk factors are. Now we will move on to the heart score for acute coronary syndrome. This is used in emergency departments. So the mnemonic itself is heart, which is history. If the history of patient is highly suspicious for ischemia, they get 2 points. If the history is moderately suspicious, it's suspicious but not highly suspicious, then they get 1 point. If patient has slightly or non-suspicion / clearly non-cardiac history, 0 points. EKG or ECG, if there is significant ST segment deviation, elevation or depression, that's not explained by left ventricular hypertrophy or bundle branch blocks, they get 2 points. If it is non-specific abnormalities like isolated T wave inversion, non-specific STET changes, they get 1 point. Normal ECG, 0 points. Age, 65 or higher, 2 points. 45 to 64 is 1 point. Less than 45, 0 points. Risk factors, do they have 3 or more major risk factors for coronary artery disease? Like MI, PCI, CABG, stroke, TIA, peripheral arterial disease, anything like that. So they will get 2 points. 1 or 2 risk factors, 1 point. No non-risk factors, 0. Now, T stands for troponins. High sensitivity are the preferred one or gold standard ones. Is their value more than 2 times the threshold for decision making or upper limit? Yes, 2 points. Is it less than that, but still more than 1 times the normal or the upper reference limit? They get 1 point. It's at the threshold or below the threshold, then it's normal, they get 0 points. All right, I hope this makes sense to everyone. We will now go on and discuss a couple of cases on how to do the heart scoring.